Sir, shall I start?
Yes, please.
Yes.
Go ahead.
Yes. Respected personalities from everywhere who are participating in this meeting. All of you, I think all of you know about the strategy Kerala is using to tackle this problem. We have one experience previously, that is in the Nipah case, and at that time it is a newly emerging zoonosis, and we were not aware at that time about this kind of newly formed viruses. Yes, I think it. Yes.
Yes, please carry on.
At that time, that the Nipah incident occurred, we discussed with the expert team, and also we searched in the literature standard operating practices we can adopt, and we formed our own protocol and our own means relating to all other parts of the world, and collecting information from all parts. We formed a very good protocol and also a standard operating practice for Nipah case. And first of all, we know that the most important thing is the screening and also isolating this affected person from others and giving proper treatment. Treatment means not only physical but also patient should be mentally stable, and we arranged each and everything in that time. And we had a very good team for contact tracing. That is also a important part, how to trace the contact of the persons who came to contact with this affected people. That's a difficult task, but our team did it in a very good manner, and we got all the contact at that time. That kind of activities is our experience. And when this case occurred, this COVID-19 case occurred in Wuhan, China, that news came in some of the electronic media. And when I read it, I felt something in my heart, because the experience of Nipah is with us. And I called my Health Secretary, Rajan Kobragade IAS, and I expressed my feelings to him. A new kind of SARS virus is spreading in Wuhan, China, and it is in the family of this coronavirus, severe acute respiratory syndrome, and also this Middle East respiratory syndrome, MERS, and it will be a dangerous virus. And we started our preparation here, because so many Malayali students are studying in Wuhan University, and we are sure that someone will come from Wuhan to Kerala. As we expected, some students and other passengers came from Wuhan on January 27th, but at that time, January 24th, we had formed our control room, and at that time we had met our rapid response team meeting and formed our control room in Kerala. Not only in state level, but also we passed the message that one kind of a virus is spreading in Wuhan, China. Beware of that. We have Nipah case with us, and our preparedness should start at that time itself. And all the district, we formed control rooms before the Wuhan case occurred here. As we suspected, January 27th, a flight came with passengers from Wuhan, and we screened them in the airport. And at that time, we formed a strategy that we should screen the foreigners who are coming here. And if there is a symptomatic case among them, at once we shift them to the hospitals where we formed isolation wards. And if the If no symptoms, but they are coming from abroad, we are shifting the persons, that people to their home for strict quarantine. And we give advisories to them. Please stay in your home in a separate room. Don't use the common toilet. If you have no facility for common single toilet, separate toilet, please inform us. We will arrange separate room for us in somewhere. And we ask them to follow strict quarantine. Even we fixed a notice in their door of the room that giving all the instructions how can use their foods, who will serve their foods, what is the precautional measures while they have they cannot be contact with the relatives, but they should have to give food and water other thing to the patient, not patient but that person, and that kind of minute things also we were insisting them to do. That incident, we can yield good result because of our preparedness. All the 3 Wuhan patients, that students who got positive by the virus, by the infection of the virus, they were admitted in the hospital and they become cured and discharged from the hospital. That was the first phase. That's over. But the virus we saw that is said not in the, we always quote that book of Sainath, that some kind of these pathogens are taking flight and flying to other countries. That is the world situation now. And this virus flight to this Italy and UK and all other part of the world, that everyone know about that. And we again started strengthening our awareness and preparedness. And we decided to have a mock drill in March, month of March. We know that any time it will come to us. And at that time, not a mock drill, we have to act in the field, not a mock, but actual thing we have to do at that time. Because some Italy patients came here and we got cases from them. Some UK passengers came here. Some foreigners were here having virus. And we tested properly, we screened them. And the method is screening and home quarantine or isolation and treatment and discharge, everything. For discharge also, we have very good protocol. I am not explaining everything. I want to hear from you because we are looking everywhere to get some more advices how to proceed. Now Kerala flattened the curve. All of you know, and we all know that it is not possible to prevent this completely, but flattening the curve is the most important thing. And in Kerala, we flattened the curve properly. And our this virus, it is saying that this virus, this infectivity rate is very great, fatality rate is low, but no use of that because the infectivity rate is very high. R0 rate is 1.5 to 3.5, it is saying like that. And it may, as a progression, this atomic chain reaction like that, it is spreading from 1 to 4 or from 4 to 16 or 16 to more numbers, etc. We have to break that chain. That is the most important thing. And we started a campaign to break the chain, breaking the chain, to promote hand wash and also to promote keeping social distance. That also we did parallelly. And all these activities helped us to flatten the curve. Now the doubling rate in India, it is in Maharashtra, it is 72 days. 7 days. And our Kerala, the doubling rate is below 7. And we achieved this because of our preparedness and continuous work. And we have now, yesterday we have 491 cases, 481 cases. We tested 23,000 samples, that is PCR test. Once we tried to have this antibody test, we got some kits from ICMR, but when we try our validation, we found that that is not good. The result is not reliable, and we sent the message to ICMR. At the time, several states did same thing, and at last, central government declared don't do with the kit, don't do the test, and we discard the kit. We are now trying to get more kits from other places. If we get that kit, we will do the antibody test also. And PCR, in the case of PCR test, Kerala is in front. But adding this antibody test, Maharashtra is in the front. They did large tests using this antibody test. But ours is all the PCR test. One more difficulty occur. If anyone can suggest anything, I am presenting it to you. That we have more testing labs now. At the beginning, we have only one lab in Alapi. That is our respected Prime Minister's place, Alapi lab, virology lab. But now we got permission from ICMR for 14 labs. Out of them, 12 are testing continuously. 2 are preparing for testing. And we can test more than 3,000 samples at a day. But the problem is the scarcity of the RNA extraction kit. Reagent, it is sufficient here, but RNA extraction kit, we are facing a dead shortage for that. And we cannot increase up to a limit the number of tests. But yesterday, we took 3,000 samples according to the instruction of our Honorable Chief Minister. We collected more than 3,000 samples, correctly 3,056 samples, and it is running. I think today evening we got the result of that samples, whether a bulk positive case are coming or not. But we cannot do 3,000 tests per day because of the scarcity of the RNA kit. And how to solve the problem, I don't know. That is the situation here. Now in Kerala, some of the districts become out of the coronavirus, and some newly are getting new cases. That is Idukki and Kottayam. That is not from foreigners. That is from our neighbor state. The major source is now become Tamil Nadu, where we share the border with Tamil Nadu. We are getting some cases because they are coming by walk through the border. Police forces are there and they are preventing them because we cannot cross the borders of state now because of the lockdown. But they have so many relationship with our state, Tamil Nadu people, and here we have a relationship with other state also. They are coming and going, and we cannot identify who is Tamil Nadu person, who is Kerala coming and back, going back. But we are putting a very good police watch there. We are trying. This is the situation in Kerala. Now yesterday we have 481 cases, out of which only 163 is in our hospital. All other persons cured and discharged from the hospital. A curing rate, recovery rate is also high in Kerala. And 3 died, out of which 2 of them are so many comorbidities with them, and they died out of that. But we can count it to be a corona death because they have positive. They were positive. And 1 4-month-old child also, that's a pity case. But by birth, the child have congenital heart disease and so many other difficulties. And growth also, it is low weight and other like that. And the child also passed away. And that is the situation, only 3 deaths, but we cannot predict whether the curve will increase or the coming days, whether any surge occur or not, but we are fighting hard. All of the departments, we have financial problems here. Our Honorable Finance Ministry is sitting there. a very great financial crisis throughout the country, and for Kerala, it is special. But he is never saying that no, there is no money, you cannot buy this thing or that thing, or you cannot appoint new people, new staff. He is never saying like that. He is helping us more than anything, because helping health department, giving money to buy these inventories and medicines and all other things, our Honorable CM is leading in front with the convergence of all the departments. And this is the case in Kerala. And what is next? For that purpose, we want to get advice from the experts throughout world and throughout India. And so many personalities are sitting in front of me. And I hope we will get more advices from you. Sorry for a long speak, because I have to explain what is happening in Kerala. Finance Minister insists me to do that. I will not speak further. It is your time, and I will hear from you, and I will note everything in my diary, and I will convey it to our health team, and we will work more efficiently after this discussion. Thank you for our Finance Minister for arranging this kind of very good discussion with eminent personalities. Thank you, everybody. Then we can start. Sir.
Why don't you, Dr. Iqbal, come up? Yeah. Dr. Iqbal, are you there?
Hello, am I audible? Am I audible?
Yeah, you are audible. Yeah. Dr. Iqbal, you open the discussion. Hello. Iqbal, there must be a phone near your speaker. No. Dr. Iqbal, can you hear me? Okay. Sundaraman, I think Iqbal will come later. Hello. Oh.
Rajiv Sadanan.
Yes. Yeah. Please, Sundaraman, you start the discussion. Open the discussion.
Have I unmute? I think to unmute me from that side. Unmute me from that side.
No, you please go ahead. We are seeing you, hearing you. Please go ahead.
You're able to hear. Okay. Let me first start by saying I've been very closely following the good work done in Kerala. And I was very fortunate that even while the Wuhan outbreak was happening, I had been invited to visit Kerala's healthcare system and look at its developments. And I spent the second or third week of January touring North Kerala, 2-3 districts, where I visited a number of sites and looked at all your programs, and I have submitted a very detailed report. So there was a good background I had. And this is the first thing that you learn about managing an epidemic. The best time to start work is 5 years before it happens. Once it happens, there is so little you can actually do. And the things that happened partly because of Nipah virus, but don't give too much of the credit to that virus. There was a whole lot of other things, including the palliative care program, the way the local self-governments are engaged, the way that you had developed a system of outreach to you actually have a situation where every self-government, every panchayat member and ward can count right on its fingers the number of cancer patients they have, the number of chronic kidney patients they have, the number of post-transplant patients they have, the number of paraplegics they have, the number of people on all. They can just tell it out. It's remarkable. I don't think anywhere in the world I've seen that ability. So all those who require today under COVID-19 shielding, which I've seen the finance minister referring to as reverse quarantine. Internationally, they use the term of shielding. These are patients that are shielded from this. You already have a system in place by which you can reach out. So when you get your contact tracing done and you are able to home quarantine a huge number of people, whereas in most places they would quarantine about 10 to 15 persons per COVID-19, you are doing about 200 home quarantines per COVID. And that home quarantine requires a very, very good system of outreach, which this whole palliative care and this notion of outreach and sub-centers has actually provided for you in a very good way. The other major advantage that Kerala has had, which it has acquired over these 4 years, was this entire national quality accreditation scheme, which has been picked up with great enthusiasm below. I don't see that so well projected at the state level, but at the ground level, I see them working on it and they have fine-tuned it very well. So that in every section, they have looked at quality process. And of course, in quality process, infection control is the most important thing. Now, in all these viruses, you have the major source of infection becomes the hospital itself. Source of spread becomes the hospital itself. You have also a high degree of health worker affliction. You can see that in Maharashtra and in Delhi. Whereas Kerala has been relatively spared that, and if it has been spared that, it's because of the work that it has put up in the periphery on hospital healthcare infection control, what we call nosocomial infection control. So I think this excellent work on nosocomial infections, which has been, is another great strength that has helped Kerala. I think there's a third feature that is again not quite the healthcare system, but which has helped, is a complete lack of stigmatization, a relative lack of stigmatization. I've seen the other states suffering from intense stigmatization. If people come around to ask for fever, the advice would be to go in, run in, shut the door, take a paracetamol, not get caught out and be sent to a quarantine or isolation. In such a system of breakdown of trust and cooperation and friendliness, where it is a policing act, and I'm very, very afraid when you use the police even for inter-border things, that will only mean that people will hide. At some point, they have to self-report. The moment they feel ill, they should report and they should actually get. And that degree of trust which you have built between the local governments, between healthcare workers and the population, that friendliness that exists, I think is a resource that, whereas you find in many of these places, there's a huge degree of issues. There are other things that Kerala has in its health systems, of very good logistics. Before I have been, in my earlier visits, critical of Kerala's logistics. They had procurement, but in distribution, this time I was seeing very good. And now when you have to move a lot of health commodities in a very responsive way to very varying demands, I think that has also been to your great benefit on that. So there are a whole lot of strengths that have actually come into play. But my sense is also of caution. This is a complex affair, and a complex affair, we define complexity as bringing up a child as a good example. You may do very well when the child is below 5, but you may lose the game when it is an adolescent. You may then not be able to take care of what you are a good parent at one time doesn't work out. And as the game changes and it matures, what you need to do changes. And at some point, what success there is at one point need not translate easily into what you need to another point. It is not just a continuation of the same. The game changes. One of the fundamental changes of the stage that you are in is that the central role must become the disease surveillance architecture. You should not be confident that only known chains of transmission where you can contact trace will come. Okay, now with some people across the border, sometimes you're saying it's beyond 30 days. The game is that you will never know exactly where the next cluster will come, but it is a predictable way it will come. South Korea has done remarkable success. Iceland has done remarkable success, but they continue to generate 40 to 50 cases in a week. This sort of cases, because essential services come in, people will come in along with that. The border will never be perfect. Even in international borders, it is not so. China is having from Mongolia and the USSR a steady traffic of new cases along their borders. They are having to take care. So the borders, and I don't think a restrictive way will be there. We should actually live with it. We should be able to contact, trace, and isolate them. We've done it, but it's not a one-time thing that we are eliminating the disease. But what we are doing is preparing for endemicity. And that important role that we are not, the goal is not complete elimination, which may be there for time spaces. But basically, managing a continued endemicity requires a very good surveillance. And the key to surveillance is testing people with fever, with symptoms, maybe cough, because you have, I believe, a lot of non-fever cases, cough. It is not enough if we are testing people who are at high risk because of healthcare workers and other things, but you do need to test people with fevers. And at some point, you can even use clinical diagnosis where test kits are not available, and you can seriously think where there are a lot of negatives of using this technique called pooled samples. Maybe you are working on it. I know Kerala would have heard about this, but at some point, so that you reduce your test kit requirement, but you need surveillance, because eventually something ridiculous happened at the national level. The country has a very good disease surveillance program that was built up after the swine flu program and has been producing weekly reports of outbreaks ever since. Every week's report is there from 2012 till the first week of February. The last report is a brilliant 3 case studies of Kerala's COVID-19 patients. And then the report goes silent. Reporting on the IDSP stops being seen in the public domain after the February 2nd week. And now actually they have even the reports flow has stopped. So at a time when an epidemic is happening, the central vehicle of managing an epidemic, the data-driven management of an epidemic, that has closed, but this has great implications for this. So I think this is one thing. I'll stop with 2 more. Do you have time? Can you give me a sense of, can I make 2 more points? Now, the other point that I really want to mention is, in China and in Spain, when they build up COVID-19 capacity, they build new hospitals, or they add on surge capacity, special temporary hospitals that are built in. In India, when we have taken 1 lakh beds additional, the Prime Minister talks of it, I am concerned that what we have done is only replaced beds. We have repurposed existing very vital secondary and tertiary care beds which are providing essential services for the poor and converted them into COVID-19 dedicated hospitals which can push out patients which the PMJAY will not be able to cover for a number of reasons. So in some sense, how do we continue with non-COVID care? This is a big problem. In other states, I have reports, which I don't have from Kerala, but I have of increased newborn mortality, increased maternal mortality, increased cardiac mortality. Now, at some point, without a disease surveillance system, without our mortality statistics kicking in, we may be paying an exponentially increasing price for non-COVID mortality. This has to be really factored in. If, for example, 3 weeks I don't take my anti-diabetic drugs, my diabetes will go out of control. But if I don't take for 6 weeks, I am likely to die of it. So there is an exponential decrease between when denial of healthcare occurs and it shifts over a long time. There are great dangers in shifting, and we are operating the healthcare system for 4 reasons: lack of public transport, a lot of private clinics have closed down, a lot of clinics have suspended services because of COVID-19 positivity. There has been a sharp decline in other healthcare that as a public health professional, I'm seriously bothered about, because as this game, it's a long game. It's going to be there for till the vaccine arrives, which the good news is it will come by the end of the year. But at some point, for 6 to 9 months, we can't continue with this degree of restrictions. Healthcare restrictions need to move very fast. I think that at some point, if we are able to either build such, definitely pushing our poor patients into tertiary care, into private hospitals, for a government that has invested so much in strengthening public health services, and you have become the model of it, and we are setting with great delight to use this to actually push a lot of care into private sector should not be something that would happen on this. A final one challenge to you is, you have done some work in your medicines production, manufacture of medicines production. This game is going to last a long time. There is a good case for being able to, like South Korea, Iceland, the first thing they did even before they started other measures was to ramp up their own indigenous test manufacturing capacity and their manufacturing capacity in some of these vital areas. I think there is a case for indigenization even within the Indian context, for being able to be, because at some point the rapid diagnostic kit is a particular kit that requires a lot of on-field to and fro validation. It needs a sort of fine tuning. It takes some time to stabilize. And if you actually have such systems built in the long run, because pandemics, believe me, are going to be around, if not this, different variations. Look, how many pandemics we have had within the last 20 years. It's not, if you start with the HIV one and call it a pandemic, it's a different type of a pandemic. The swine flu, the Nipah virus, the SARS virus, the Zika virus, the whole areas. It's not every 3 years we are having it. We need to be thinking of some generic capacities where we can able to ramp up. So these are the sort of concerns that I think in the long run, because this is a new world we have arrived at, and we should be. Even on protective equipment, some of these self-reliance is going to be required in a major way. So I think I'll stop with this and pass it on to others.
Yeah, excellent. May have some remarks on your last point, but at the time of discussion. Now, Dr. Iqbal, I'm very happy to see that you're also available on video. Why don't you join us? Hello, Dr. Iqbal.
Can you hear me? Can you hear me?
Yeah.
Yes, we are hearing you. Please go ahead.
No, I may not be visible. There is some problem. So I am showing my photograph here. In fact, I wanted to be visible. I wanted to be visible because I am wearing the same.
Shade of Iqbal is there on the screen.
I wanted to be visible because I am wearing the same type of jubba my good friend and the finance minister is wearing. Unfortunately, I could not do that. Anyway, in response to what Sundararaman said also, I would rather like to say that the current situation in Kerala can be summed up as so far so good. We could pick up the positivity cases from the airport itself, treat them, trace the contact fairly well. For every one positive case, we have traced up to 100 contacts, and then we quarantined them very effectively, efficiently. 200,000 of them were quarantined, most of them in their houses, they were monitored, and everything is going on fairly well. But nevertheless, I would say that Kerala is facing large number of challenges compared to other Indian states. That is why I am very afraid. I am not very comfortable in saying that Kerala is showing the model and Kerala is better performing, etc. Because compared to other Indian states, we have other problems. Number one being that Kerala is a highly porous state. All the borders, anybody can come in from various routes, not only the established route which are blocked, like Tamil Nadu is nearby, which is a hot state. into Idiki, for example, or Palakkad, even Trivandrum, they can come in at any time. This is one problem, and we are expecting a large number of immigrants to come to Kerala someday. We can postpone it to some time, but they are going to come maybe in lakhs. Now, how to monitor them medically, how to quarantine them is going to be a major problem. And most of them will be young people who will be coming into Kerala. Now, the second problem Kerala is facing is that our vulnerable population is very huge. You know that the COVID affects mostly, I mean, not only the infection rate I am talking about, but the complication rate and mortality is high in elderly population above 60 years and with comorbidity. The comorbidity in Kerala is very high. The non-communicable disease morbidity is very high. So we have now listed them somewhere around 71.6 lakhs people belong to this vulnerable group. That means about 1/3 of the population is at risk. So how to keep a Chinese wall built between the younger people and the older people is going to be the major challenge. So large number of people will be coming from other states, younger generation, and we have to see that the social distance between the vulnerable and the younger has to be maintained. So we are doing that. We are trying to do that, but still there is a problem there, and this is a major. So we are now propagating reverse quarantine in a big way, and we are monitoring those who are at their home. Our palliative care movement is very active, because most of these vulnerable groups are lonely in their homes. Their medicines are to be brought to them, etc., etc. Now, the third problem we are facing is in relation to testing. Now, of course, Sundaraman very rightly pointed about the need for zero surveillance. In fact, we had an excellent protocol for zero surveillance, thanks to the excellent work done by Rakhel Gaidonde of the Achuthamenon Center for Health Sciences Studies with the help of National Institute of Epidemiology, LA. In fact, it's a model protocol. And we wanted to start doing the zero surveillance with the help of antibody testing, but unfortunately, the antibody kits we received, not only here, but all over India, you know, that was substandard. It could not be validated, so we could not start the testing. And therefore, we could not do the zero surveillance using antibody testing. Now we have a problem with other testing also. We are fairly comfortable at this point of time when it comes to RT-PCR testing. We have about 14 testing centers now, and the Central University opened up their laboratory for testing. The Institute of Science Education and Research has opened up. Many private colleges have given up their PCR to us. So we have somewhere around 300, 3,000, 3,500, 4,000 testing facility, and the Rajiv Gandhi Center of Biotechnology has promised another 2,000 or 3,000 if the demand comes. But nevertheless, you know that if a big demand comes, this is not enough. So the other options are the antibody. In antibody testing, another good news I have to say is that the Rajiv Gandhi Center of Biotechnology has developed an antibody kit which has been validated. The validation is of a very high percentage, and they are waiting for the note from the ICMR to mass produce these antibody kits. And the Sri Chitra Sarinal Institute of Medical Science and Technology also has developed an antibody kit, which they say they can make up to 75 lakhs kits per month. So that is possible. So it may come 1 week, 2 weeks, 3 weeks time. We hope that we will get a large number of antibody kits. Now there are others also. See, the major issue in Kerala now, not only the COVID patient, the non-COVID morbid patients. How are we going to manage them? Now we focus on the COVID patients, so much so that the mortality and morbidity of the non-COVID patients who are already there in the Kerala may increase. This is a major challenge. So we have allowed emergency cases to be managed, especially surgical cases. We also wanted semi-emergency cases to be managed. But how are we going to manage them? Because the medical profession is afraid to take care of these emergency and non-emergency cases. So we have to test the patients before surgery. If you go for RT-PCR testing, it will take at least 4 or 5 hours. So we cannot wait up to that time to do an emergency procedure, not even a semi-emergency procedure. So there are other testing facilities for safety like NAT-based nuclear testing, One is the gene expert, which is available in one medical college, and we are moving the NAT facilities from the TB centers. You know that the NAT viral testing facility was available in the district TB centers. We are moving this to the medical colleges so that in the medical colleges, we can do the NAT testing or gene expert testing within say 45 minutes, and we can submit emergency and semi-emergency cases of surgery. But what about the private sector? About 60 to 70% of the patients are managed in the private sector. There are also things could have been solved because they have purchased what is called TrueNat testing facility. This is also viral testing facilities, but unfortunately, the ICMR has said that this is only a screening test because they test only a single gene, and therefore this should be all positive cases should be followed up by with PCR testing. That is okay. We can get it tested for PCR in a nearby PCR testing lab. But this is a point of care testing facilities. But nevertheless, ICMR says that you can establish TrueNat facilities only in a PCR lab. This is a problem. So we have asked the government. In fact, yesterday we were discussing with the Honorable Health Minister. We have asked the expert committee on COVID medical committee. There's an expert committee. So that committee has requested the government to contact the ICMR and waive this particular condition for starting these TrueNat facilities in private hospitals. So these are some of the major challenges Kerala is facing. And in a nutshell, I would say, how are we going to keep a barrier between the young and the vulnerable people? This is our major challenge. But in this context, in the presence of our Honorable Minister, I would like to make one very important comment in that we need not be afraid of social dissemination of COVID. At one stage or other, it is going to come because the infectivity rate of COVID is very high. You know that the R0 value is somewhere around 3 to 4, and therefore it will come. And moreover, in a way, it is good in that it will create some amount of herd immunity. If you look at the history of epidemics all over the world, you see that only the epidemics settles down either by development of an early vaccine, which is not possible now. It may take another 6 months, 1 year, or antiviral, or herd immunity. So herd immunity has to be developed. This is a contestable view I am airing here, because we need not be afraid of a community transmission. But in Kerala, it can have this problem that we have a high vulnerable population. So therefore, when the community transmission comes, we will have to keep again this barrier between those who are infected and the vulnerable population. That is a problem, because in a way, it is a double-edged weapon. Once community transmission comes, herd immunity may develop and the disease may settle down. On the other hand, the community transmission takes place, suppose it spreads to the vulnerable section, then the mortality and morbidity will be very high. So I think that I am confident, I am very optimistic in that, because of the large social capital Kerala has in our hand. You know that in such a crisis, all with the difference of views on politics, even though there are certain controversies here and there coming up, all stand together and then try to meet this challenge. One major group which I would say that we were fighting all throughout our life was the private self-financing medical college. For information, all the 22 private self-financing medical colleges have thrown open their all facilities to the government. In fact, government with their willingness taken over the Kannur private self-financing medical college and the Wayanad self-financing medical college and made it into COVID hospitals. So therefore, you see the social capital is so big, and therefore I am confident that even if social dissemination takes place, we can take care of the vulnerable population. So this is what I have to share with you now. Thank you very much.
Yeah, that's very good. Iqbal has two issues. One about testing and some technical details. Second, regarding the shielding of the vulnerable population. Sundaraman, I have picked up your term, shielding. Shielding of the vulnerable. And that's a very large issue. Apart from health workers, local governments, counselors, palliative networks are all involved. And well, if there is time, we can come back to that. And now, Rajiv Sadananda's face I saw. Rajiv? Hello, Rajiv.
Dr. Rajesh Sadanandan, hello.
Yeah, teacher.
He was on.
A teacher, you want to take leave, please. Yeah, you speak.
Please unmute me.
Unmute your speaker and speak.
I have unmuted, but can you hear me now?
Yeah.
Now, teacher, the Shailaja teacher wants to say something, please.
Please ask someone to unmute your.
Nothing, but I want to have a word that before speaking, we are hearing from Rajiv Sadanandan. He was our health secretary, all of you know, and for this preparation that through the Ardhram mission and also in the Nipah incident, we are not taking Nipah in front of everything. As Sundaram said, there are so many other things pre-Nipah and post-Nipah here. But he who led the war at that time, and we have so many experiences at that time. I want to appreciate for that my previous secretary, and I want to hear from him.
Yeah,
Proud.
very good.
Thank you,
What
Minister,
more
for that.
clarification do you require, Rajiv? That this. So, Rajiv, please.
Thank you, Minister. The situation has been kind of where we are now has been very well explained by the Minister, Dr. Iqbal, and I was even surprised to see Sundar talk about as a Keralite rather than as an outside expert. Now, in the beginning, the finance minister had said that among the audience, there is going to be people from outside the state who would be interested in, in learning how is it that Kerala has handled this epidemic. And I guess I'll kind of respond to that. And I don't agree with Sundar that in some extent, I agree that Nipah was not the beginning and not the end. But we did have some, effect of that on the system. As you know, the capacity of the system to respond to a crisis, what we call resilience, is not built up over. I mean, is built up over time. But every time a crisis happens, it gets tested and strengthens. Now, if you learn from the crisis and build on it, then we tend to benefit from it. Now, it will demonstrate itself as it happened during the Nipah, during the 2018 flood, by the ability to reorganize itself to respond to the specific nature of this crisis. Secondly, what Dr. Iqbal mentioned, which is it's also important to keep the non-crisis work, the important non-crisis work functional, like the non-communicable diseases, tuberculosis, mental health, and so on, which is again another nature of the resilience. And also, when this is over, the speed with which it returns back to the normal, that again would be another indication of how resilient the Kerala systems are. COVID-19 is a health emergency, but it's a pandemic that makes use of human interaction between individuals, communities, and nations. And it also spreads using social functions, religious meetings, and so on, which means that this can't be responded to by the health department alone. It needs a coordinated action from many sectors. There is police, there is transport, there is education, and so on. So it also needs a high level of social capital, a kind of transparency and trust in government. Now, I would like to submit that what is on evidence now is not only the strength of the Kerala's health system, but the large social capital that is there in the state, which means that this kind of gets taken out of the health system. Anybody who responds to it has to factor this in. Anybody who wants to learn from Kerala will have to factor that in. Now, health systems are resilient if they can protect the citizens from disease and get good health outcomes during the crisis and all that. It must have built up a knowledge about the threat and early warning system to alert itself and to assess the dimensions of the threat. Now, Kerala economy is dependent on the expatriate population and on international tourism. So Kerala, right from the HIV/AIDS pandemic of the 90s or late 80s and 90s, has been alive to the disease from the to threat of disease from any part of the world. In fact, I used to joke that when anybody sneezes anywhere in the world, Kerala starts reaching for the handkerchief. So when as our minister said, when the unknown virus was reported in China and Southeast Asia, Kerala changed the threat perception, and it's almost like to the medical persons, it's almost like a adaptive immune system responding to a known pathogen. We've been there before, so the health machinery, trained by the past experience of handling medical emergencies, began to mobilize itself. In fact, at that point, I believe that we were over mobilizing, and but it's better to do more than to do less. Now, this would not have been possible without a well-trained, highly motivated workforce in adequate numbers. Like what happened in the Surat plague, most governments have chosen to respond to COVID through the government health system. For the last few years, and Sundar can bear me out on this, for many years now, the prevalent policy discourse within the health sector and outside has run down the public health system as inefficient, of poor quality, the starved of funds, resulting in underfunded, understaffed, and demoralized health system. Now, it has resulted in shortage of infrastructure, staff, systems of procurement, inventory management, and so on. Now, when you push that system, which has been run down to a crisis, the system which is not even capable of managing the normal load will crack up. When you look at the way states have responded, I see I see the way states kind of differentiate themselves. And the most determining factor to me has been the level of importance the state governments have given to health sector. Now, you're pushing medical personnel to work without ensuring their safety, limiting hours of work, and across the country, staff are demoralized, and the clinicians among you know that when the staff get demoralized and scared, the quality of care will suffer and will be reflected in the case fatality rate. I'm afraid that is what is happening. Unlike that, in Kerala, the government health system has always been highly valued, irrespective of the government that came in. You know the history: the princely rulers, the missionaries, the successive governments, and the civil society, and so on. So it has resulted in a good government health system, even though a large amount is still in the private sector. Even 2015, when you look at the national health profile, you will find that a hospital, a government hospital, a government bed, and a doctor responds to half the Indian national average. That is, at the national level, one system responds to double the number, manages double the number it does in Kerala. Now, that was further augmented by when the government launched the Ardra mission in 2016. Whose objective was to increase one of the objectives was to increase the percentage of persons using government hospitals. Now, for people who are outside the system, it is difficult to realize the huge increase in morale, the feeling of being valued that happened in the health system when the Ardra mission got into full steam. Thanks largely to the support of our Minister of Finance. We had 836 posts of doctors, 937 posts of nurses, 454 lab technicians, all created in the space of just 3 years. And in addition to this, we spent about, the planned investment went up from about 630 crores in 2014-15 to almost 1,500 crores in 2018 and 19. In addition to this, using KIFBI money, government is now investing 2,266 crores of borrowed money on improving hospital infrastructure and equipment. It's been just 4 years now, but the results are already evident. When you move from the 71st round of NSSO to the 75th round, the percentage of people using government facilities has gone up from 34% to 48%. In fact, in the rural area where most of the investment happens, it has crossed 50%, well on the way to the aim of 60%. Let's not discount the role of the Nipah outbreaks. I mean, that is what my former colleagues in the health department tell me. At the macro level, it trained managers on how to estimate a threat, identify a resource in the system that could be repurposed, and to climb down the threat was over and keep the other services going. Now, the skill of tracking and tracing, which is highly applauded in the country, was built up was learned during the first Nipah and built up during the second Nipah crisis. The supportive management of highly infective critical patients has also been something that was learned. The analysis of data to see how the epidemic is growing, the prevention of healthcare associated infections. In fact, and the psychosocial support of persons on quarantine and treatment were all skills that we learned during the Nipah. Now, after the Nipah crisis, while the rest of the country was, rest of the world was applauding Kerala, Kerala's health system went back to analyze where is it that we had got things wrong. And one of the areas identified was that a large number of infections happened within the healthcare associated, the healthcare facilities. So the Kerala Antimicrobial Resistance Action Plan, which is the first in the country, was a result was an outshoot of the infection prevent and control system that we started across the state. And as Sundar mentioned, that has had a good impact on the control, the cuff corners, the hand washing, which became a kind of religion. So this was and the other thing was that detractors had predicted disasters during the first Nipah crisis. I mean, we are aware of that. But the fact that government health system could handle it created a kind of confidence that is there even now, that wave is still there. In spite of the huge numbers that remain so. I hope the morale continues. Now, the outside the health system, there is another strong community support, which is unlike what I've seen in any other state, which constitutes the external social capital of the health system. We know about the decentralization that happened. All the PHCs are under the panchayats, and what we need to understand is the role played by the village health sanitation and nutrition committees. It has got the ward member as a chairman. It has got the health workers as conveners. It is in their job to lead on prevention of infectious diseases. So most of the Gram Panchayat members realize that this is something that adds them, that gives them a connect with the voters and take it very seriously. They also know that if they fail, then they're going to be in political trouble. So Panchayats have been using the resources for controlling diseases, purchasing medicines, hiring additional manpower. So when the Kerala government on 20th of March issued a set of directions to the local self-government department on control of COVID-19, to them it was routine. It was a successor of a long tradition of circulars in the past to manage infectious diseases. I will not get into the numbers. Frankly, I believe that talking about prevalence, talking about case fatality rate, when you don't have a scientific community system, a surveillance system, it's not accurate. Now, Kerala did get a bonus by the lockdown that was imposed, but lockdowns have been imposed across the country. The reason why it has helped Kerala to a large extent is because of the measures taken early, the community, the prevalence of infection in the community was at a lower level. But more important than that, what to me showcased the lockdown ended doing was to showcase the social capital of the state. The lockdown has been described as a strategy to protect the upper social groups who have no financial worries, could stock up provision, and had enough space in the habitat to move around at the expense of the daily wage earner, the lonely migrant, and the poor in general. Kerala responded to their plight through community action. More than 5,000 community kitchens opened, and most of that has been funded by local contributions. In the statement filed by the government, Ministry of Home Affairs, and the Supreme Court, more than 62% of the support units for migrants were in Kerala. And officials in Kerala who could speak the language got in touch with the families and kind of reassured them. As I mentioned before, the epidemic of this nature could not have been managed by health department alone. The coordination of these departments was very important, and full credit should go to the chief minister. In fact, the systems that we used was the systems that was developed during the 2018 floods, made more efficient now, and these departments now kind of dovetail into each other and present a unified front. We also know that the other important thing is the is information. During epidemic, most of the news is bad news. Governments try to hide it. When you hide the truth, the false information gets out there. This was learned in the 2003 SARS epidemic and so on. That unless the community is co-opted to the prevention and mitigation effort, it will not be successful. Kerala also learned this during the Nipah crisis. During the Nipah crisis, every day information was being given out. Same thing is being done today. During COVID-19, the government has been prompt in providing accurate information and up-to-date information to the public. Good news, bad news, the news is there. PM's evening news conference must be the most closely watched event in Kerala for recent times. What this has done is that it has earned government the trust of the people. We know that from the Ebola epidemic in Africa, we know that one of the most important areas for managing an epidemic is to get the trust of the people. Kerala believe that their government will tell them the truth, take care of them should they fall sick, and support them if they need support. In return, they are prepared to subject themselves to restrictions government has imposed. It is true that government has been successful so far. The final test of this trust will come if and when the situation becomes serious and the state's capacities start looking overwhelmed. Now, as I mentioned before, and as Sundar has mentioned, the state's capacity will get sorely tested as we move forward. The numbers will go up, and they have to go up, reach that 60% rate for the R0 to come down to less than 1. It's unfortunate, but something that we have to live with. What has worked in the past may not work. They may need to look at out of the box solutions. Slip-ups will happen. People could lose patience with the government. But finally, I believe that the inherent resilience of the Kerala society in general and the health system in particular will ensure that the Kerala will come out successful out of this challenge. And I thank the Honorable Minister for the active leadership she's provided. And also thank you for the kind words that she mentioned. Thank you.
Thank you, Dr. Rajiv. And you have one more speaker, after which we'll take a quick 2 minutes each response to certain issues I will identify from your presentations, which are important for the next day. And then the Health Minister will sum up our session, and another 15 minutes. So, Dr. Ramankutti, please come.
Okay, am I audible?
Yes. Oh, sorry, Dr. A.V. Jose, the discussion will be.
Yeah, after
Ramankutti.
Okay, if I'm audible, I'll start. I want to thank the Gulati Institute and the Honorable Finance Minister for this opportunity. And most of the things I want to say have already been said, so I will not belabor all those points again. We are right in the middle of the pandemic in 2020, and definitely Kerala has come out well so far. And as they say, the proof of the pudding is in the eating. We have patients only in hundreds and deaths only on numbers that can be counted on our fingers, which is itself very good, so that is so far so good. Even India as a whole has not done badly, even though in some states the numbers are bad. But while this is a reason for satisfaction, it is not an excuse for smugness or relaxation. Coming to Kerala's performance, all the things that have so far been said, I want to emphasize again. First is the fact that we were prepared, and I think the Nipah is an important lesson of how to deal with an epidemic, which we had an experience a couple of years back and also repeated last year. But not only the Nipah, but we also had the floods, which taught us a lot of things. One is how to handle, emergencies, and also how to work under common leadership and across sectors. Like the health sector was not alone in dealing with many of these things. They learned to work with other departments, which is very important. So And I think that has been a huge benefit for the state. And of course, the very fact that the very fundamental fact that we have a very educated population, and this very traditional asset, social capital, which we have, and a very good, active media, which meant that messages have been correct messages have been spread very fast, and people have responded to that. Then secondly, we already have a very robust public health system, as been pointed out. Even though most of the beds are under the private sector even now, but still we have a very well-functioning public health system, which has been boosted in recent years by initiatives such as the Ardhram, which the former secretary talked about. It's very commendable initiative, which I think needs a very detailed study at some stage. So these are factors which are because it acts at the primary healthcare level. It acts at not like you're spending money at the top, but at the bottom. So that is very important. The infusion of personnel at the primary level is a very important thing, which some of us have been clamoring for some time. That at last it has happened. Thirdly, I would also again emphasize what people have pointed out, that is a decentralized health governance, which again has had a long experience of dealing with epidemics, as like dengue, leptospira, and other things, which has always been managed with the help of local politicians and local panchayat leaders and community leaders, which is very important, which has actually been very useful in the development or the organization of the community kitchens and ensuring food security in the rural areas and also among the the less affluent section of the population. Also the very proactive public distribution system, which also contributed very much. But there is one thing which other feature which is has been to our advantage, but which people are talking less about. But it is, I think, we have to acknowledge that this is simply the fact it's a chance that we got less number of cases. Most probably one of the reasons is that we had a less infusion of the virus into the population. This is because if you take countries like the US and Italy, even after the epidemic was notified in China and people knew about it, it's been estimated that about 5 lakh people traveled to New York from China, which is you can imagine the number of people who brought the virus. That fortunately has not happened for us so far, because we don't have direct flights to the epicenter of we didn't have direct access to the epicenter of the epidemic, and so that probably has contributed less. If you look at even across India also, if you look at the number of cases coming out of Maharashtra, one of the reasons probably could be that the international airport in Mumbai. So that's a very important factor. So what this means is in the future that when we open up now, we find that a lot of resident Keralites are queuing up from the Gulf states, and they are registering the NORCA registry for coming back to Kerala. And this is going to be a big important factor when we go forward, and we should have systems in place which will screen them and which will probably isolate people if they are found to be infected. I'm sure the system will be ready to take care of it, but I'm just flagging that issue. And we cannot rest back on our laurels saying that we have very few cases. Of course, the game is not over. There is a long time yet to feel that we have things under control. So this is very important to remember. But we also should know that one thing that Dr. Iqbal pointed out, that there are many people who say that since the epidemic started, there has not been so much of a rush for other things in the hospitals, which they're saying in a way that it means that people have been using hospitals because it has been overuse, over medicalization. I don't think so. As a doctor, I think that this is a very wrong view to take. I think people are postponing things, and people probably are not getting the treatment that they want. And as Dr. Sundararaman also pointed out, there's probably be a backlash as chronic diseases and all those things will come up, and we will have to deal with that. And I think the system should be ready for that. And for that, of course, we need to also boost the state's finances in health, probably of course, that's a major challenge also. I think these are all the things that I want to say. I will stop here because most of the things have already been said. I think the only thing I would want to emphasize is that the game is not over yet, and we have to be ready for it's getting perhaps more complicated in the future. But I'm quite confident that the system can take care of that. Thank you.
Thank you. Now, Dr. A.B. Joseph would respond as a discussant very briefly. Then we'll have one more round.
Very briefly, let me say it was a very educating experience being here, listening to the presentation by Srimati Shailaja teacher, who gave formidable leadership to the state in walking through the crisis as it arrived, and took us to the kind of place where one could look back with comfort. But then she made use of, or she strengthened the firewall that was extended in the state, extensively made use of the network of professionals in equipping the state to deal with the crisis. And what came out was a very humane response to the crisis that was unfolding. And I think Kerala did an extremely commendable job, and I should place on record with the rest of the world appreciation for the kind of leadership given by the health ministry and the doctor and the honorable minister therein. But then, as was shown by the members, the distinguished members of the panel who commented on what next, and there were extremely interesting insights which came in, and I'm not going into the technicalities of it. They were extremely competent. They pointed out to the instances there might be shortfall. We ought to be prepared, the areas which require a lot more care. But then one thing which disturbed me is that when normalcy returns, if it ever does, because life has changed all over the world, can we ever avoid the predicament of the West, where people died in droves all over in major cities? You might say it was a heavily urban-centered phenomenon, but the fact remains the vulnerable age groups of the population just died off, with the society unable to extend to them the care which they rightly deserved. And we are as much vulnerable to that kind of a situation, because compared to the rest of India, we have a very high share of the aged population within. That doesn't mean that we are not a caring society. The fact of the matter is we lack the kind of extent institutionalized care facilities which need to be created. One more point. I think it's time we moved on to creating durable institutional facilities that can ensure access to good quality healthcare. All the panelists, including Dr. Rajiv Sadanandan, they went into the kind of creation of the infrastructure being done with amazing dexterity, excellence in Kerala. One is not going into that. We are doing a wonderful job on that front. But then the question is, with the private sector, they ought to be able to compete, which means we ought to create insurance-based systems, contributory insurance-based systems, accessible to every person in Kerala, where they can be equal beneficiaries of the kind of sophisticated medical care without any shortage. One has got to think in terms of creating appropriate institutions, and I hope at a later stage, when normality returns, we will be able to take this on board. Thank you. Let me not go into the details.
Yes, we'll have one brief round, and then the health minister will sum up the discussion. It is extremely fruitful, the whole discussion, the best I've heard on Kerala's health response to the crisis and the health emergency. I think the panel should respond to 4 issues which you have mentioned in your presentation and which are going to be very important in the coming months. The first is the health minister touched upon it, Sundaram and everyone. What is going to be our, the return migrants? Okay, have you got any comments on the preparations made, how we should handle it? Two, one thing that Joes was had referred to, how to shield our vulnerable population in the time of the return migration and the crisis that inevitably will come. Three, that shield require, Dr. Iqbal was insisting on the test, that intensify the test even further. But the minister was saying about the test kits availability. How does the next few months look like? I would say, not the future, but next 2 months. And finally, something that Sundaraman said, when we exit from this crisis, what are we going to take? Of course, a much more resilient health system. But you mentioned something more. Kerala health system has never brand value, upon which we can build up, say, a pharmaceutical industry, medical devices industry, perhaps finishing schools for nurses. We seek out employment opportunities in the West and so on. So this achievement of the health sector becomes a very important launch pad for something that's larger. Therefore, I would say the possibility of expanding pharmaceutical medical devices sector in Kerala. So these are the 4 issues, I think, which are very important. We can quickly go, then Peter will summarize. So we follow the same pattern. Sundaraman, please.
Here. Your sound, we can hear.
Can you hear me now?
No.
I can hear. Can
Yes,
all
yes.
hear you?
Yeah.
Sorry.
So I'm saying on reverse migrant, I think you're the masters. I mean, I'm not going to, I think you guys will get it really right. You're going to set up district centers. You're going to make sure they come in phases. You're going to tag them. You're going to follow them up through. It's a lot of doing. I don't think that's, it's just the physical volume of what you have to do is the issue. But I think you'll have to break it up into component parts. And if anybody can do that, I can see Kerala doing that. And I think this is a big thing. On shielding, I already made my point. And I thought that nowhere else in India have you got a system that is so tuned. It wasn't built for this. It wasn't built for this palliative care system. But it is going to actually work wonders on this. Because in some sense, it is really fine-tuned. You already have people out there, you'll have to strengthen them. You'll have to provide more kits. And I think somewhere one has to be more looking at the details of this virus transmission. For example, if people take a walk out to the park, and even in Public Health England, there is a rule that says that you can take a walk to the park alone or with your family member for 1 hour. You don't have to be frightened of shielding. Should not be seen in a very literal way. It should be worth living. You don't rob them of the joy of living. If they are old people, let them meet people. So I think a very humane approach to shielding. I'm sure you will get to it. But I'll skip the thing because there are others to speak. And I say what we are from the rest of India looking forward to Kerala is also something that can be used to strengthen democratic movements and the right to health all over India. Isaac, you must know, I was talking to Iqbal after I had made my January visit that we need an international conference on primary health care in Kerala. After the Alma Ata thing, to really say that there's something more that I had been pointing out you need to do, but after a year, now coronavirus changed the game. But having said that, I thought that there was a need to showcase type of what we can do under such conditions in a neoliberal world show a certain model of healthcare. Now that global supply chains are breaking down all over, now that there is a different type of crisis happening in the international economy, I think in the health sector, Kerala has a possibility of being able to show a very different model, not only in healthcare delivery, in the entire structure of health industry that needs to be created. So, with these few words, I think I'll pass it on to the others.
Thank you. Dr. Iqbal.
In fact, there is yet another problem Kerala may be facing in the coming months. That is about the pre-monsoon showers are coming and the monsoon is going to come. It is the time when we are going to face the infectious diseases. In fact, Kerala is a highly morbid society. We are facing double disease burden. On NCDs on the one hand, non-communicable disease about which we were referring to, but also the infectious diseases are also there endemic in Kerala, especially dengue, leptospirosis, and H1N1. These conditions present with fever. Even though clinically we can very easily distinguish between COVID and these conditions, when they come in large numbers to the OP, and fever being the common symptoms, it can have a problem. We have already a fever protocol, and I think that we will need to change the fever protocol, taking COVID also into consideration. And in our primary healthcare center upwards, we may have to keep the fever patients separate with the OP. Otherwise, a community spread can happen at that level. So the health ministry is aware of this. They have already convened a meeting to discuss about the pre-monsoon activities with LSGs and education department. But I would request the minister once again to alert all that during the monsoon regime, these diseases are likely to come back and mix up with COVID. And it may be at that time the immigrants are coming to Kerala. So the whole thing will be, we will have a lot of things to do at that time. So I think I would request the minister once again to alert every related departments that we should take care of the monsoon related infectious diseases. And with regards to the international conference to which Dr. Sundararaman was saying, we were thinking about that. It's not only Almata. We are talking about Astana conference. The Astana Primary Health Conference was held in 2018. And surprisingly, Astana moved a little in advance of Almata conference, because Almata, they exclusively confined on health promotion, health education, etc. But when it comes to Astana, you see that even at the primary healthcare level, they are talking about disease prevention, treatment, rehabilitation, and palliative care. So in fact, if you look at the Kerala primary healthcare level, in fact, our finance minister quite often talks about this. I would say that he is a palliative care evangelist. Dr. Thomas Isaac is a palliative care evangelist. In fact, his old experience in the monastery has helped him to be an evangelist. So whenever I go to therapy, everybody comes and says, this is our FM's idea. So therefore, I think this is appropriate time. Once the COVID is over, we will organize the international conference on primary healthcare in Kerala. Thank you.
Dr. Rajiv.
CT Kurian, NRAM, CT Kurian, NRAM, they are all here. Some question from CT NRAM. NRAM.
Say, Rajiv, NRAM wants to raise some question with you.
I'll read it out. I'll read it
yeah.
out. No, so, I think we are very happy to learn that there's quite a lot of activity through the YouTube, and we are very happy to learn that Professor CT Kurian, he says it is very interesting session, and we have Sri NRAM saying it's educative, and he has a question. Any of the panelists could answer. Yes. Question is, does Kerala has enough RPE for medical and health workers? This is a question raised by Sri NRAM. Thank you, Sri NRAM, CT Kurian, and of course many others. We thank you. This is a representative question.
Dr. Rajiv.
I repeat the question, Joseph. I missed that.
Question is, does Kerala has enough protective equipments? for medical and health
Okay.
workers.
Right.
That's
No,
the question
one that
which
was
we
a major
enrolled.
concern when we started, but I understand that the problem was that we had the same problem in during Nipah crisis, and PP was flown in from Dubai by a philanthropist to handle the crisis for us. This was noticed when in January itself. I believe the Kerala Medical Service Corporation went to the market and tried to buy the PPEs. They were not available. But situation has changed now, and right now, even if there's a shortage, it is possible to go to the market and get adequate number of PPEs. But as Dr. Sundaraman mentioned, things are going to change. The kind of management that we did for cases in the past, which is treating each case as if it were an ICU management, will change. And as the number of cases go up and as the style of management changes, I believe the per capita requirement of PPEs are going to come down. So my hunch is that the market right now across India, the availability of PPEs have gone up, and it should be a lot easier to get them now.
Okay. Well, he
Yes,
reinforces the point that trust is very important, social capital, which you raised. Sri Enram was reinforcing the point that trust is crucial.
Yeah, I think this is something that.
Okay, Rajiv, your response.
Yeah. Okay. Now, regarding, first of all, I'd like to assure Dr. Jose that normalcy will come back. I've lived through so many epidemics that where the Armageddon was predicted, and fortunately that didn't come around. And a lot of people ask me, what happened to the disaster that you predicted? And we keep claiming we averted the disaster. So I guess maybe a year and a half from now, we'll look back upon this, and that'll have the answer to your question. But as I mentioned before, if we can use this crisis to redesign the way we do things, that will be a major opportunity. Now, Dr. Iqbal mentioned about the people flooding the hospitals for fevers. Do we need that? In NHS and other places where primary care is practiced, a lot of these have shifted to teleconsultation. Can we move to a model like that? Can the private individuals, private doctors who take care of patients as and when they walk in, move to a kind of prepaid system by which they assume responsibility for the health of the individuals? Can we rework that? So there are huge opportunities for us to rework the primary care system and the rest of the health system as we get back to normalcy. That brings me to the question that has been missed out, which is Kerala during the Nipah crisis and here have not invested adequately on research. I think we are depriving India, we are depriving the world of how to run a proper system on a low-cost basis. And my request to the Honorable Minister and to Dr. Iqbal is, look, it's time to devise to use this as an opportunity for research. This is an opportunity that will not, we missed it during Nipah, and I think we should do it. We should do it now. Now, regarding testing, it's also linked to the issue of the migrants. With the present expensive mode of RT-PCR testing, it's highly unlikely that we will be able to manage the load that comes in. What some of us have been pleading right from the beginning, something that ICMR refused to heed, was NIV should have invested on antibody testing. Now, what ICMR's position was that antibody testing will not be good for clinical, is not good enough for clinical management. One, at some point, testing for clinical management is going to become irrelevant. But more importantly, for epi research purposes, had we got the antibody tests on time, it would have been a great help. What we still don't know is, while many of the other viruses are able to confer immunity on the people who have been infected, does COVID do that? The question is still open. But assuming that it is so, and the question will be answered by the time the migrants come back, one good thing will be to administer antibody test to them, find out if they have been infected in the past, and look that for the entire population also. Identify people who have developed immunity and then use them for your frontline work. Again, that's a science question that is resolved. Now, Kerala should continue to look to collaborate. It was mentioned about the test developed in Rajiv Gandhi Center, the test developed in Srijitra. We are being overly deferential to the ICMR. This is a crisis, and NEPA. When NEPA happened, we didn't look at many of these conventions. What are we afraid of now? Why don't we collaborate with the research institutions in India and validate those tests and lead the rest of India rather than trying to follow them? I mean, it's a risky decision. I hope the policymakers will give thought to that, because when we lead, others will follow. And I think we need to invest heavily in trying to validate the different tests that have been there. We have enough number of people, cured patients, who can validate antibody tests. So my request to the government of Kerala is, please collaborate with the well-known researchers in the country to validate some of these tests. I'll stop with that, because why I'm saying this is important to our management of the migrant issue. I'll stop with that. Thank you.
Thank you. And now finally, Shailaja teacher will sum up our deliberations. It has been extremely useful and fruitful, and the kind of messages that we are receiving, I'm not going to read them all. Everybody, not only appreciates what has been done, the way it has been elaborated. Please help Minister.
Thank you, sir, for having such a fruitful discussion. And I will keep the major points in my mind and make use of that suggestions for our further planning and preparedness. I want to respond only main points which raised here by all of you. And the major thing is that what is the Kerala model? Whether it is related to health department only. We can never say like that, because 1957 onwards, we have a separate planning, separate mode of planning, and separate kind of people-centered methods. We are implementing that. As a state of very low financial fitness or condition, it's no one can believe that how Kerala reached to a social development culture in our society. It's because of the people-centered planning. Definitely, we can say so. A different method. Now, the whole of the world are discussing what is happening in Kerala. Some are discussing about the socialist or communist planning. I don't know whether we can say so now. But there is something in it. I say from 1957 onwards, we are doing some experiments in this sector. One is that our Land Reform Act and other thing, each and every one, almost all the people got some land in their ownership. And the other is the education reform and the public education system. We can say it's a proud to Kerala. That's why the people educated well, 100% literacy. And also in the health sector, from this beginning itself, from the A.R. Menon's, that the first health minister of Kerala, and that government implemented something for improving the public sector to get treatment to the poor people. And we are now following it up to 2020. We are following it, and we are making some refreshment and some advancement on that basic structure. And we are doing more experiments in every time. Every time we are doing that. When the new LDF government came to office in 2016, as you mentioned here, what is the condition in the health sector? Rajiv Sadandan was the secretary at that time. We studied the contemporary things well, and we decide what we can do on it. We found that out of the total population, 67% of the population is going to private sector for the treatment. What happened to our well-built public sector? It is spread all over Kerala. In each and every panchayat, we have a primary health center, a hospital, PHC. And we have sub-centers for 5,000 population each. And we have secondary level, very good taluk hospital and also district and general hospitals. And we have some established medical colleges also. But why the people are moving to private sector? And it is said that out-of-pocket expenditure is very large in Kerala. And we want to answer that problems. And we decide to have some improvement or some revolutionary work in health sector. We are preparing for the primary healthcare improvement, but at that time, government's mission, one of it came to health sector called Ardhram mission, as Raji Sodanathan stated earlier. And we prepared a very good action plan for Ardhram, in which we decided to have some principles, some findings of Astana and Alma-Ata conference, World Conference, giving importance to the primary sector and to prevention. And through Ardhram mission, we converted more than 300 primary hospitals to family hospitals. And 500 more hospitals are being converted to primary hospitals, and the work is going on. And we decentralized some activities to the primary hospitals, not only the infrastructure, people's friendly infrastructure and technologically fit infrastructure. Not only that, we added some clinical practices in the primary health level itself. CHOS clinic to test the COPDs and Ashwas clinic for mental health, etc. Then the common people can directly come to the PHC for testing their health. And that is a very good practice, and that helped us very much to prevent this kind of infectious disease and also to have some prevention on it. And we are doing that things continuously. And in secondary and tertiary level also, we made so many things. And as mentioned here, through the KIFBI fund, I want to express my thanks again to our Honorable Finance Minister. We got more than 2,300 crores of rupees to the health sector to build very good hospitals, to install new instruments to the hospitals, and we improved the condition, the infrastructure, and also the functioning of the institution. I want to say that we gave the 3 super specialities, that cardiology, nephrology, and neurology. That was there in the medical college only. And we shifted the super specialty to these secondary level hospitals also, to the district hospitals. We installed cath labs there. Now the angiogram and angioplasty are doing there. This kind of activities, I'm not explaining each and everything. This kind of experiments or activities that helped us very much in the health sector. And the infection control, for infection control, we did several things. We got awards or the NQAS awards to more than 60 primary hospitals in our state. All the first 12 primary hospitals selected by central government is from Kerala. And more primary hospitals are waiting for national quality accreditation. They got more than 90% marks. And that is because of our improvement in the primary sector and hospital infection control. That is the main area we worked last 3 years, 3 or 4 years. It also helped us very much. This is not our own work. We can say LSG. We had a have a lead role on it, because after the decentralization, all the hence institutions are forward to give it to this local self-government, and they are having some funds for the development of their primary health centers. I'm not explaining. And it is a people-centered method. The common people give us donation to build the primary health center to family health centers. And that is huge number. If we fund, we utilized only for the secondary and tertiary hospitals. For primary hospital, we are collecting funds from people. So many CSRs and company CSRs and individual donations we are getting from society. That is why we are saying it is a people-centered method, a different method adopted by Kerala, which everywhere can use as a model. And for the infectious disease, we have two threats in front of us in 2016. The time is going, but I am not explaining. That two threats are, one is infectious disease. Not only Nipah and Corona, but dengue is here. Everything is here. H1N1 is here. And we have had a kerchief revolution to prevent H1N1. We can say so. With the help of local self-government, we implemented that thing in some places. And also we started a campaign that every day we have to do some preventive activities to tackle the problem of infectious disease, Arogya Jagrata campaign. And my health is my responsibility. That is our slogan. And we are doing that thing. And the non-communicable disease, as everyone said here, Kerala, because of the lifestyle, because of the improvement in the life conditions, we can say so, we are suffering from non-communicable diseases and lifestyle diseases. Especially Kerala is the diabetic capital of India, we can say so. And the population, because of our development of social sector, the life expectancy also increased. We have a very good percentage of population more than 60 years age, and that is vulnerable group. On one part, it is a positive thing, and the other part, it is a threatening thing when this kind of infectious disease occur. And we are doing some work on that arena also. And we have declared reverse quarantine during this corona period. And with the help of Social Justice Department and the Women and Children Department, we are doing that thing to protect the vulnerable people from this deadly virus. And we, each and every day, our Women and Children Departments, volunteers, workers, Anganwadi workers and helpers, they are interacting with the old age people. And on health sector, ASHA workers are going to their home and inquiring about their health conditions. And if anyone become any serious illness, we are directly taking them to the hospitals and treating. We are not denying treatment, that normal treatment in the period of coronavirus. We are eagerly watching them, what is happening there. And with the help of our NCD control wing, one Mr. Vipin Gopal, doctor, is leading and doing a very good work. But we are giving NCD medicine to their home. Home supply is there. For 2 months, we supplied NCD medicines to the home for these vulnerable people who are in reverse quarantine. In that way, we are managing that things. And a very good result we got that. Now, we cannot say that a huge number of old age people are getting corona here. That is because of our preparedness and planning on that. And as our finance minister said, the preparation in future, that also we are thinking. And with your suggestions also, we are implementing these things in our health sector. And I'm lucky that I have very good officers with us previously, Sri Rajiv Sadanandan, who laid a foundation stone for the development. And now Mr. Rajan Brigadier, sincere officer who is working hard. So many of them in district level, DMOs and DPMs who are working hard, who are shouldering everything, and they are doing very good duties. We can say Kasaragod district hospital, general hospital, they shouldered these things in a proper way. They have 89 cases, and today I have a very good. I want to share a happy news that everyone who were admitted in Kasaragod General Hospitals was discharged. The last patient discharged today, and they were very happy. I have a video conference with that team, and I found how the team building was done there. Each and everyone had a duty, and I asked them, it is not time to stop it. You want to continue. You have to continue all these activities because we cannot say that Corona is over. And sometimes it will come back to the to that place also. And that point, how to shield the vulnerable, I addressed that not only old age people but also the differently abled people. We are doing some exercise to have them some video conference and other thing for the training and the physiotherapy and other things for the autism, cerebral palsy student, these children also. We are doing in a very good manner. And the requirement of the test, that is the most important thing. Sri Enram inquired that whether we have PPEs in sufficient number. Now the PPEs we have in a sufficient number, but in the previous stage, in the starting stage, we have a very good we had a scarcity of PPE also. No stock in with us, and we inquired where we get that thing. We are not manufacturing PPEs in our state properly, and now we are thinking to manufacture that. And someone was ready to stitch the PPE and N95 mask, but the problem is that we are not getting the raw materials. That was coming from China, and when China shut down, we are not able to get that raw materials properly. 2-layer, 3-layer mask, no problem. It is in sufficient number, but the real scarcity is for the testing kits, especially this RNA extraction kit. And ACS said that we should have to examine other test methods also. Several people are coming with the new methods of testing, that this antibody testing, etc. The problem is the validation. We have to validate it properly, and if we succeed in the validation, we can make use of that that kind of tests also. Runa test is there. Several kinds of tests are there. We are experimenting on it. We can say we can get a very good position in testing future days. And also after the Corona season, what we can do? There's a question in front of us. Our government under the leadership of Chief Minister is trying hard to face the problem. That we want to save, we have to save not only lives but also livelihoods. After the shutdown period, what happens? The economy will, I think, fall into a difficult problem. And all the production, all the manufacture, everything will stop at that time. We have to suffer great problems. We are trying to tackle that problems also. And I am not saying word by word to all of everything. And we have so many practices here. AMR reduction plan, that's a model thing for Kerala. We are working on it. And cancer strategic action plan, again a novel thing in Kerala, prestigious action. And so many action plans we have, and so many that are being implemented in Kerala. We are working on it. And the thing is that we have 4 airports for this small state, and from everywhere these viruses are coming into everywhere in Kerala. Airports are a good sign of development. But during the pandemic season, that become a hotspot. We have to work on it. We are working on it. Anyway, we are doing so many more tests, and we are improving our preparedness, and we are waiting. We are expecting the worst and hoping for the best. That is our policy. And again, I want to thanks to our finance minister who is helping us very much. And Dr. Iqbal is there, is the advisor. That we formed an expert committee to discuss the major problems, and Dr. Iqbal is working sincerely on it. He is giving so many points to us, and I want to convey my thanks to Dr. Sundararaman. He visited Kerala, as he said, before I think 6 months or 7 months before, and he visited our primary hospitals, and he appreciated for the function of the hospitals there. And I want to convey my special thanks to Sri Sundararaman for giving such a great suggestions to Kerala. And also Dr. Iqbal is with us, and Rajiv Sadanandan, he is retired, but every time he is with us. I am calling him almost alternative days to have some advices from him, and he is giving advices to us. Thank you, ACS, for giving so much time to us. And also Dr. Aminkuti, as Dr. Aminkuti said, we are in the middle of the, that's a very, I want to underline that word, we are in the middle of the pandemic. And Sri Dr. A.V. Jose, sir, I thank you very much for understanding the actual problems and our preparedness in Kerala. And thank you, everybody. Thank you very much, sir.
Okay. Thank you very much, everyone. I just want to have a clarification made. Some people have been writing shouldn't blame other states. Far from it. Absolutely no blame. Only a statement of fact.
Yes.
In fact, somebody can blame Kerala that you brought the pandemic first case.
We will never
So
do.
no blame, no blaming of others, nothing.
We will never do,
But
sir. We
how
will never
can,
do.
yeah,
We are not the
Kerala and
masters.
Tamil Nadu have porous borders and relations extending over such a long period is very normal, and we have to go to live with it. Absolutely no. And I want to make an announcement that many of you are discussing local governments, and Gulati Institute of Finance and Taxation and Kerala Institute of Local Administration, KILA, they are organizing a webinar